Hello everyone. So for today we're going to be explaining the hematology mid-unit revision, which consists of week 2 material. Hopefully it's going to be straightforward, easy and short. Okay, so for the contents we're going to be covering all the disciplines starting from pathology, pharmacology, immunology, genetics, physiology and finally histology. Okay, let's start off with pathology. Now for pathology, there are two main concepts that we need to focus on, which are leukemias and lymphomas. However, leukemias in pathology lectures are more shorter and more general, but if you go back to the hospital lectures, you're gonna find more details. But what I knew is that in the hospital lectures are excluded from your mid-unit. So for that reason, it's gonna be very, inshallah, short for leukemias. طيب. First of all, we need to differentiate. What's the difference between lymphomas and leukemias? Lymphomas are known as a solid tumors. You would actually palpate a solid tumor, whether it's in the lymph nodes, so palpable, or in the bone marrow, or even in the thymus. Okay, and we have two classifications for lymphomas, which we'll be covering, the Hodgkin's and the non-Hodgkin's lymphoma. Then for the leukemia, it's more of a liquid content. It's not a solid tumor that you would detect. So it would be, for example, an increase in the number of, in the blood cells, in the blood or in the lymph generally. Okay, starting off with leukemia. So, for this part, it's very important for you guys to know the risk factors of leukemia. So the main risk factor could be mostly is congenital or genetic disorders. And most commonly over here is what we mean is trisomies, whether Down syndrome or which is trisomy 21 or any other trisomy. Okay, and then also Fanconi anemia. Now this type of anemia, we're going to cover it very briefly in the hospital lectures. And then finally, ataxia or any congenital anomaly or disorder that affects the nervous system. Now there are other drugs or chemicals that could increase the risk of developing leukemia, but they're not very important for the exam, for the sake of exam, but still go through them just in case. Okay, so starting off with the classifications of leukemia, we have acute and we have chronic. So for each, we have the lymphocytic and the myeloid leukemia. So we have acute lymphocytic leukemia. What you need to know over here, very important, it's the most common cancer in pediatrics or in children specifically. Okay, yani it's the most common leukemia in children. It's the most common cancer generally in children. Okay, it's the acute lymphocytic leukemia. Then you're gonna have the acute myeloid leukemia. Now, yes, okay. So let's go to the next. We have the chronic leukemia. The most common type of leukemia will be the chronic lymphocytic leukemia. And then finally, we have the chronic myeloid leukemia. Now, these two have many characteristics, especially microscopic characteristics and features that you need to be familiar with. So refer back to your OSPE slides and pictures. Okay, another thing, the first thing that we need to differentiate between acute and chronic is in terms of symptoms. Generally, when we talk about acute, these are very important. If they get you a case scenario where they tell you there is easy bruising, there is discoloration, there is the pallor, all of these discoloration, signs or symptoms, and bleeding, of course, since bruising is basically bleeding or hemorrhage. So these, you see these, معناته it means it's acute. Now, another thing is shortness of breath. This is another sign of acute leukemias. And finally, two things, bone marrow and infection. Why bone marrow? Why bone marrow specifically? Bone pain. Bone pain, because sometimes the bone marrow would have accumulation of cancer cells or malignant cells. This would interfere with the normal functions and these aspects. So you would develop pain in this area, specifically in the sternum. Okay, so like in the chest, upper chest, thorax. Okay, for the chronic, now we know in any, let's say, cancer, two main symptoms you would experience, which are unexplained weight loss, which is a drastic weight loss, which has a certain criteria that you do not have to know, like within how many months and the percentage of this weight loss. For number one, weight loss. Number two is night sweats. هدول in any cancer, chronic cancer, these are found. But another thing, a very characteristic feature of chronic is having swollen lymph nodes or lumps, whether they're in the neck, in the groin, in the axillary area, and even feeling a sensation of fullness in the stomach and bloating. So this means that chronic is highly it's asymptomatic لأنه it's chronic, it's happening over time. So of course when something happens over time, your body is gonna start to like adapt. So therefore it's not gonna have that much of noticeable symptoms, unlike in the acute where you would have bruising, bleeding, hemorrhage, tenderness, bone pain, and so on. Okay, now number two, the thing that you need to distinguish between acute and chronic is the features. What you need to know in acute is that the leukocytic cells or the cancer cells are highly aggressive, and they develop very quickly within a short amount or within a short period of time, and they are immature in form. Three things: they are immature, develop very quickly, and super aggressive. Okay, unlike in the chronic where you would have a better prognosis لأنه the cancer cells are developing super slowly and they are mature. فلأنه when they develop super slowly, this means they have time to grow. You're gonna see them as mature cells in the microscope. Okay, and these cells would be normally functioning, unlike in the acute. Sometimes they would have certain dysfunctions. Okay, acute is known to happen in the pediatric age in children, where in chronic they're more in elderly. How do you remember acute children? Okay. طيب, now going on, starting off with the 4 types of leukemias, acute leukemias. Let's start off with the acute lymphocytic leukemia, ALL. How do you remember it? It's the most common cancer in children. Let's say it's all cancer in children. طيب, what type of leukocytes would you see, or leukocytes or WBCs would you observe in this type of cancer? Is immature lymphoblast. When you see a lymphoblast, this means it's immature. Specifically, we're talking here about the precursor B cells. These would be the cause of this malignancy. Pre-T would be also a cause, but pre-B is the most common cause. طيب, again, all is an age group of children and young people, but specifically it's in children. Clinically, what you would see and observe is growth failure of the bone marrow, and therefore sometimes you would see retardation of growth in these children. طيب, and also you would see peripheral blood infections and anemia and so on. Why do we have a lot of infections and stuff like that? لأنه in the bone marrow we have growth failure, صح? Therefore you would have accumulation of malignant lymphoblasts. This would give you some manifestations like infections, hemorrhage. Why infection? لأنه we don't have enough WBCs produced to protect you from any infection and so on. You would also see hemorrhage لأنه my WBCs and even platelets are not well functioned. They're not fully developed. Okay, and these are some clinical manifestations. Bone marrow, since it's acute. Lymphadenopathy, obviously, since we have a bone marrow over here dysfunction or a growth failure of the bone marrow in children. CNS involvement is also important, but we're going to see it more observed in other types, which you guys will see now. Okay, for the acute myeloid leukemia, in this, usually when they give you a case scenario, sometimes they may give you the ranges of the the number of the WBCs, the platelets. In this case, you need to memorize these numbers sometimes, especially for the hospital lectures. Know the range. مثلا platelets minimum of 450k platelets, 450,000 So you need to know some numbers in these. For example, in AML, okay, in labs, what you're going to see is that you're going to have leukostasis or leukocytosis, increase of WBCs, but a decrease in platelets, thrombocytopenia, okay? Plus DIC is very important over here, the disseminated coagulopathy. طيب. And then another very important feature, which may be a trigger for you in the exam once you see this word, is aleukemic leukemia. What does this mean? When you look at the cells, okay, in the peripheral blood smear, you're going to see that the cells are variable in sizes. You're going to see blasts, you're going to see big cells, which is atypical for leukemia. Therefore, you would know that this is aleukemic leukemia. plus a very very important feature over here, very very important, pancytopenia. Pan يعني total cytopenia. You're gonna see decrease in WBCs, and therefore you're gonna have infections. You're gonna see decrease in hemoglobin, so you're gonna see anemias. You're gonna see decrease in platelets, so again you're gonna see bleeding, bruises, which is again seen in acute leukemias. Okay, so pancytopenia, leukemic leukemia, leukostasis or leukocytosis accompanied with thrombocytopenia, all of them, they indicate AML. Okay, another thing which was mentioned in the hospital lecture, you guys may refer back to this for your final, is that there is an equal incidence بالmales and females over here. يعني there is no predisposition والله in males or more in females. No, it's equal. Okay. طيب. Yes, another thing, finally, since we finished acute leukemias, you need to know the FAB classification. Very important. Hala, I'm not telling you to know the L123, the M207. No. What I mean over here, يعني for example, in AML, you're going to see a chromosomal abnormality, which is a translocation between chromosome 8 and 21. This is a key feature. أول ما تشوفوا this, خلاص, it's AML. Okay, and you're going to see something بالmicroscope in the blood smear. Is that, I'm not sure how do you pronounce it, but I guess it's the air rods. You're going to see these, which are basically, يعني you're going to see the blood, the RBC, the WBC, or the RBC, يعني, and then you're going to see like small, like, I don't know, like small lines. These indicate air rods. Okay, so these are very important. These are like your marker in the question. If you see them, خلاص على السريع AML. طيب. We also have another translocation, which is this is not very important, to be honest. يعني just double check with your doctor if you need to know them. But I know for the myeloid leukemia, and you have 7 subtypes. Let's say 8, and it's from 0 to 7. Okay, no need for these. طيب. Yeah, another thing is that in CML, this is very important. This is يعني I guarantee you're gonna get a question on this. You're gonna see with CML إنه you have a chromosomal abnormality or a translocation between chromosome 9 and 21, and this indicates something called Philadelphia chromosome. طيب, this is very important in both hospital and pathology. طيب. Another thing which you may get in the question, يعني they won't expect you to know the type of leukemia from the stains, but it will help you if you see it, يعني. طيب, which is in ALL, it's gonna have the pass, it stains upon pass stain. طيب, but in AML, it's gonna stain, it's positive for student black and peroxidase stain. This is just for your information. It may help you بالexam. طيب, now if you go to chronic, chronic CLL, it's more in elderly. This is very important. Knowing the age groups is very important for knowing the type of leukemia. And sometimes you may not understand the entire question, but when you look at the age group, خلاص, you're gonna know يعني directly, this is, for example, chronic CLL. طيب. Yes, over here, a very important thing to know is that you're going to see lymphocytosis of B cells. مش leukocytosis that we saw previously in the acute leukemia. No, over here, lymphocytosis of B cells. And يعني, of course, increase of WBC expected. This is leukemia because, but this is your main target, increased B cells. Again, there is a condition which is the small not again, this is something new. You have a marker over here, another thing, which is the small lymphocytic lymphoma, So basically, under the microscope, you're going to see a lot of small cells. This can be an indicator of CLL. Okay? هلا over here we can also tell إنه CLL is a subtype of Hodgkin the hair cell leukemia. Okay, this is just an addition. It may come in the exam. I saw it in one of the questions. طيب, we're done. Another thing for CLL very important is a triad. 3 things: lymphadenopathy, hepatomegaly and splenomegaly. For both the spleen or the liver are enlarged, and برضو you're gonna have a lymphadenopathy. If you see these 3 together accompanied مع بعض, خلاص على السريع, it's CLL. طيب for the chronic leukemia, now this one usually affects median age يعني 55 to 60, not إنه above, لأنه over here we said it affects like over 65. These details sometimes can be important for you إنه to help you to answer the question if you don't understand any of the other given information بالquestion. طيب over here بالCML هلا how do you remember إنه what's the feature of this؟ أنا I remember it as كمل بالعربي يعني كمل. it's gonna be an uncontrolled production أو proliferation that is بكمل okay it's uncontrolled of granulocytosis, specifically يعني an increase in the number of the granulocytes. إيش هم؟ we have most commonly is the neutrophils. If you see an increased number of neutrophils السريع, this is CML, which is an uncontrolled production of these cells. هلا generally you're gonna have thrombocytosis مش thrombocytopenia which we saw previously, و hyperleukocytosis يعني it's not a specific marker بس over here thrombocytosis و granulocytosis of neutrophils is very important. Generally you're gonna see splenomegaly anemia يعني not something specific, but what's specific here is two things. Or one thing, let's say, it's the abdominal fullness accompanied by, or yeah, two things, abdominal fullness and abdominal pain, specifically in the lower upper, in the left upper quadrant, okay? This is the location of the spleen, so you're gonna have an enlarged spleen in this area. طيب فلأنه we said we have uncontrolled production of granulocytosis, specifically the neutrophils, this means this condition is also known as a myeloproliferative disease. Therefore how do you remember again؟ بكمل كله على بعضه proliferation one over the other. طيب next, okay, so by now we're done from the chronic myeloid, chronic lymphocytic, and also the acute conditions. Okay, this is just for your not for your information, but like it's a quick recap. We said that CML is MPD, proliferative disease, okay, and we said that CLL is accompanied by the hairy cell lymphoma plus the small LL. طيب, and also بالAML we said that we're gonna see this type of condition. طيب, these are some facts. As we said, the most common type of leukemia is CLL. Most common neoplasm or cancer in children, we said all, which is ALL. And most common adults, not very important, but it's يعني AML. This is a microscopic picture just to show you what do I mean. For over here we said we have كمل, right? Proliferation. It looks like a crazy picture. You can see a lot of proliferation. Look, it's like a lot. طيب. بالAML you're gonna see, as I told you, air rods. This is how they look like. They're like needle projections. You can see them cytoplasm. They're like زي هيك. Okay. Normally this is how a blood smear would look like. يعني you would have a typical neutrophil يعني 1 to 2 بالblood smear. But when you see this craziness, it's CML. When you see this air rod or this needle structure, it's AML. And then بالALL what you're gonna see is that this is more of OSPE. You're gonna understand this microscopic picture in OSPE, but you're gonna see very rare, like a very small amount of cytoplasm accompanied with enlarged nuclei. Okay. طبعا usually in your questions they're gonna get you pictures, especially بالhospital. Not only that the case will help you to know the type of leukemia, but also the picture. يعني sometimes you may not understand the case, but when you look at the picture you understood the practical aspect, خلاص you're gonna be able to answer. طيب, part 2, which is lymphoma. We're done from leukemia. Lymphoma is also very easy يعني. So we have two types of lymphomas. We have the Hodgkin's and the non-Hodgkin's. Now you need to differentiate يعني. I guarantee you this is gonna come in the exam, at least one question. So what's the difference between Hodgkin's and non-Hodgkin's? هلا the involvement of the disease يعني. Over here بالHodgkin's you're not gonna find extranodal involvement. كله it's gonna be localized. For example, in the axial group of nodes, whether it's in the cervical, mediastinal, para-aortic, in this, like, it's a localized area. But when you see a non-Hodgkin's, how do you remember? It's everywhere. It's none. It does not want to go follow a rule. It's everywhere. It involves an extranodal involvement. طيب. More frequent in the multiple peripheral nodes. شوفوا periphery, فإتس like outside لبرا. طيب و something else is the type of spread. بالHodgkin's you're gonna see an orderly spread of the lymphoma. Over here it's non-contagious spread, فإتس more of a diffuse. And this is for example Hodgkin's. شوف like look over here, it's more of a cervical مثلا axial group of lymph nodes كلهم ورا بعض orderly in order. بس for the non-Hodgkin's we said none, فإتس not following a certain order, it could be here everywhere. طيب. These features are very important for you also to know for the lymphomas. Hodgkin lymphoma specifically occurs in young adults and in teens. You don't need to know the age بالضبط. But two main symptoms that are very important to know is non-tender enlargement of the cervical lymph nodes, okay, plus accompanied with fever and night sweats. For fever, night sweats, plus the non-tender, no pain lymphadenopathy, cervical lymphadenopathy, خلاص, this is Hodgkin's. Okay, we have also some subtypes. This is more for your OSPE. They won't ask you specifically in explain each, but go through them generally, the 5 subtypes. But you need to know طبعا this subtype is under Hodgkin's, not non-Hodgkin's, and we call it the right classification. This is important to know. هلا ignore this, not important. Non-Hodgkin's you need to know the Burkitt, I guess that's how you pronounce it. Burkitt lymphoma, it's classified as a non-Hodgkin lymphoma, very aggressive, very bad. It's involved in the mature B cells, and also in B cell. يعني it's if they ask you what type of cell is involved, you would say it's a B cell tumor. Okay, nodes that are involved, لأنه it's non-Hodgkin, فإتس extra nodal. طيب. This is very important. It is due to an infection, the Epstein virus, and it's also which causes a translocation between chromosome 8 and chromosome 14, and you would see the MYC oncogene. This is very important to know. Work it in it's non-Hodgkin. These are questions for you to know. The answer over here is B. Okay. I explained over here briefly because it's an elderly patient. We have low hemoglobin and we have low, يعني we have thrombocytopenia. So it's gonna be the CLL. Let's next question. Again, it's an elderly person. We have over here, if you notice, information over here is not very significant. It won't tell you much of the condition. But if you look at the picture, that's going to help you. That's why I said practical pictures. بالmidterm, they may not be important. I'm not sure. Refer back to your doctor. But generally, بالfinal, pictures are going to be very important. يعني شوفوا, you're going to see a lot of small cells. We said this is CLL, which is accompanied in the chronic CLL. Okay, so again, this is for you guys to go through. A 30-year-old from the age group, you can tell it's an acute, it's an AML. Okay, finally, last question. بدون ما تطلعوا أصلا, when you look over here على السريع, you're gonna know this is Hodgkin's. Why? Because we have a feature which is the what do you call it? It was binuclear. It has a certain name. It's an owl-shaped cell with nuclei. So directly, you're gonna say this is Hodgkin lymphoma. You may not understand this now, but when you study your practical slides, you're gonna understand this. وطبعا another feature, حتى if you don't understand this, painless. I said painless, right cervical adenopathy. على السريع, this is Hodgkin lymphoma. And this is the final question. Again, I said non-tender cervical lymph nodes, fever or night sweats على السريع. This is Hodgkin lymphoma طبعا. The clinical picture. Okay, now let's go start off with physiology. Physiology is super simple. You're just supposed to know the general features of the leukocytes and the WBCs. Very straightforward. أصلا it's kind of like a recap of your foundation year. طيب, again, I'm just going to go through this very quickly and it's super easy. We know that WBCs, we have agranular and granular. We have 5 types طبعا of WBCs. The rest, يعني we have 2 that are agranular. يعني there is no granules in them, which are 2 macrophages, or let's say the monocytes, and lymphocytes. And we know what are lymphocytes, which are B and T cells. We know that T cells are subdivided into multiple cells, which are the helper, the cytotoxic, the Tregs, And yes, and for the B cells, we have the antibodies, which are grouped as games. No يعني 1 2 3 4 5. طيب, now we said إنه A granular we have 2, which are the lymphocytes and the monocytes. The granular are the rest, the 3: basophils, neutrophils, and eosinophils. Now, basophils, you would generally see them in inflammation and allergy, which we already know in IgE, which is released in this case. And for the phagocyte, okay, for the neutrophils, we're done with basophils. We know that they're associated with inflammation and allergy. But the neutrophils, eosinophils, they are known as phagocytes. They phagocytose. They're known to have this feature, which is phagocytosis. But the weakest in this procedure is eosinophils. But the most potent is neutrophils. Okay. طبعا macrophages are also considered to undergo phagocytosis. طيب, and also something that you need to know generally, in the monocytes, when they're in the blood, they're called monocytes. But once they're in the tissues, they're called as macrophages, and they transfer via a certain factor, which is MCSF, which is the macrophage colony stimulating factor, which is stimulated by certain hormones, not important for you to know. But this is generally very easy. It's just an overview. Generally, again, we have certain functions, which you guys are by now must be familiar with. We know that eosinophils, you see them mostly elevated in parasitic infections. Okay, they have certain mechanisms to undergo and to fight off the pathogens or the parasites. For example, they would release hydrolytic enzymes, release reactive forms of oxygen, and certain proteins. These are not very important to know, but just in case, know them. Basophils, again, I said, they're involved in allergic reactions or inflammatory. It's an inflammatory mediator, therefore it's activated by IgEs when you have an allergy. And this release is mediated by histamines, heparin, all of these, bradykinin, and so on, serotonin. All of these, they cause vasodilation and decrease in blood pressure. Okay. Now, whenever you have an infection, the first responders would be your neutrophils, and then secondary, you're going to have the macrophages. And usually we know that macrophages, they're the ones that are responsible mainly for the engulfing pathogens and dead cells, debris, and dead bacteria. Now we have the immune cells. Now for the immune cells, we already know this. We have innate or acquired. Innate, we know it's very generalized, but acquired is more specialized, it's more specific, and it's acquired. When you are predisposed or exposed to an infection, you're going to develop an acquired immunity. But innate, خلاص, you have it since birth. Acquired, again, very briefly, we have T cells و B cells, the antibody mediated, and T cells, which are cell mediated. Okay, we know that antibodies, they are fast responders, while that T cells are slow responders. For this piece of information, I found that in multiple lectures, some lectures say the T cells are more efficient, while in others it is less efficient. Just make sure, I don't know if the slides have changed for this year, but double check if there is any overlapping in this aspect. Okay. Next, finally, for macrophages, what you're supposed to know is that what's the name of the macrophage in this certain type of tissue. In the liver, you call the macrophages Kupffer cells. In the skin, once they penetrate the skin and go into the epithelium and so on and into the connective tissue, you call them histiocytes. مثلا in the lung, we call them alveolar. These are the main: alveolar in the lung, Kupffer in the lung, in the liver, and histiocytes are in the skin. Clinical aspect, they won't ask you directly a question, but you should be familiar with them. We have two types of leukocytic disorders, which are leukopenia and leukocytosis. Leukopenia is a decrease in the number of WBCs, while leukocytosis is an increase. When would you have a suppressed immune system? Is when you have leukopenia, low WBCs. We don't have enough pathogens to fight off. Therefore, this could be due to use of certain drugs or antibiotics. and therefore certain physicians would tell you, I would prescribe this antibiotic for a certain period of time because we don't want to suppress the immune system. Also, when it's very severe, it's a severe chronic infection over time, of course, يعني your immune system will eventually be suppressed. Okay, هلا if we go to the leukocytosis, an increase in the number of WBCs, we have most commonly is the lymphocytosis, an increase in B or T cells, and a granulocytosis, which is an increase in the neutrophils. So we call this condition neutrophilia. Sometimes you would see leukocytosis in pregnant ladies, or even when someone exercises. When you stress on yourself, you can have an increased number of WBCs, and even pathological disorders, one of the most common, which we just discussed, pathology, which is infection.
Okay, now continuing off with genetics, I'm Reem, and I'm gonna continue with the revision of week 2. Okay, so basically we're gonna start with the molecular pathogenesis. Leukemic mutations are often going to affect the transcription factor. We always know that any disease might have a genetic factor and may have environmental factors. When it comes to leukemia, genetics mutations are very important because the majority of the time they're often the cause. These mutations are going to promote the cell proliferation and inhibit the cell differentiation, and as a result you're going to continuously have a large amount of cells that are not differentiated and unable to perform their function, and as a result we're going to have impaired hematopoietic regulations, because if the bone marrow is constantly just producing one type of cells while the others like RBCs and the plasma, the platelets are not going to be produced as much, you're not going to be able to have a balanced hematopoietic regulation. Now, chromosomal abnormalities are frequent in hematological types. So it's most oftenly that a leukemia is as a result from a chromosomal abnormality. Now, what are these abnormalities? It could be either a deletion, in which you lose a part of the chromosome, an inversion where you have reversed the order, so like you moved it from one place to another. If you could look at the picture right here, so the purple was here and then we switched them in place. And then we have duplication. It's basically when you're supposed to have one segment, but by mistake or something happened, a mutation that happened resulted in two segments present on the same chromosome. Translocation is that when two different chromosomes translocate parts of them. So for example, let's just say this is chromosome 8 and this is chromosome 9. Part of chromosome 9 moved and joined chromosome 8. Part of chromosome 8 translocated onto chromosome 9. Philadelphia chromosome. As Malak mentioned, Philadelphia chromosome is especially important in chronic myeloid leukemia. It's caused by a translocation, meaning there was a part from one chromosome that fused with another part. If we looked here, we can find that chromosome 9 and chromosome 22. Normally, on chromosome number 9, you find ABL. ABL encodes for a tyrosine kinase receptor, which is important for the proliferation and the growth of the cell, while chromosome number 22 is responsible for a BCR. A Philadelphia chromosome results when the ABL segments on chromosome number 9 is going to translocate and fuse with the BCR segment on chromosome number 22, resulting in chronic myeloid leukemia. Okay, and it's basically a translocation type of mutation. Now, if we were to look at how this chromosome is going to lead to CML, you can see that it is going to produce a hybrid protein. This, despite the fact that ABL translocated from chromosome number 9 and went to chromosome number 22, it still retained its ability to code for the tyrosine kinase domain. And as a result, the tyrosine kinase is constantly being active, and the cell is going to undergo uncontrolled cell division. Now, there are several pathways that would lead to the activation of this BCR-ABL. It either could be the RAS, which is a part of the signal transduction. It could be MIC, which promotes the proliferation. And if it was AKT, it will enhance the survival. It's very important to know which one stands for what, because they might ask if a BCR-ABL pathway that was activated by RAS would most likely cause signal transduction. Now, the clinical relevance of this is that Philadelphia chromosome is the hallmark of CML. And basically, based on the fact that we know that this Philadelphia chromosome is related to the active tyrosine kinase, we'll be able to use targeted therapy by using tyrosine kinase inhibitors. Now, after we have understood how there are different molecular pathogenesis that happens, you can see how you can actually diagnose them using two ways: the fluorescent in situ hybridization, also known as FISH, or the reverse transcriptase polymerase chain, اللي هو RT-PCR. So we're going to start by the FISH. Basically, what they're going to do is that they're going to, let's imagine this is a segment of the DNA having different codes. What they're going to do is that they're going to cut it into small segments. It could be either an RNA or an DNA. Then they're going to attach a fluorescent dye onto these segments and then use a matching or a complementary probe. If the probe was able to detect the segments, that means this gene is present there and there was no mutation. But if there was a mutation, it won't be able to detect it. And this is what you can see here. So now the green one is the ABL, and then the red one is going to be the fusion between the two. So ABL is the green, BCR is red. You can see how the probe detected them individually. But then you can see here this fusion indicates the presence of ABL, BCR, and this is detected by the probe. Also, reverse transcriptase is a very important molecular diagnosis because it's going to help us find out the BCR ABL transcription based on the breaking point locations. These three breaking points are very important: the micro, the minor, and the major. And then more than 95% are caused by the major breakpoints. And then they could be either present after the exon or after the introns. But here, since they're present after the exons, you're supposed to know these two. They tend to have a better prognosis. Then both fusions of the mRNA are going to be translated into P210 BCR and ABL oncoprotein. So here, those diagrams or those pictures are going to be present in your slides, and they're indicating at the different sites where the breakpoint happens. So you can see here the major happens between B2 and B3, while the, I think this was the micro, happens between these two, and then the minor happens in between these two. Depending on their different segments, they're going to have different transcription. And here we can see the fusion between the transcription of E1 and E1 and A2. So these diagrams are just basically explaining the concepts right here. Then after that, we're going to use the reverse transcriptase to formulate the complementary DNA from the RNA strand. So this is going to be the mRNA. We're going to use the reverse transcriptase and we're going to form the DNA segments. After we get our DNA segments, we're going to use gel electrophoresis, in which you can find the presence of the segments. What you're gonna or what are the different lanes? It could be the DNA ladder, the normal, the B2A2 positive, B3A2 positive, which are basically these two segments right here. So if they were positive, they're going to show up on the strands right here. Okay, so the presence or like the presence of a white line indicates that this gene or this mutation is also present. Now, another translocation that occurs in cases of leukemia is the AML1E2O. So basically, AML1 is a gene that's located on chromosome number 21, and it encodes for AML transcription factor that is responsible for the differentiation of the hematopoietic stem cells. This usually AML1 gene forms a complex with the core binding factor beta. Then this core binding factor beta usually is going to be is going to bind to this DNA segments of TGTGGT. Then it's going to recruit the cofactor. Then we're going to have an active transcription factor, which is going to promote the cell differentiation and mature into normal blood cells. Now this is the normal process. What happens in cases of leukemia or in cases of AML is that instead of binding to the cofactor, we're going to bind to the copressor complex. This copressor complex is going to prevent the normal cells from differentiating. That's why we're going to have acute cases. So they're not going to be differentiated, and they're going to inhibit their differentiation. And this will also enhance the self-renewal capacity of the blast cells. So the form of cell is going to be, instead of site, we're going to have the blast, which means immature. Finally, we also have the PML-RARA gene. The retinoic acid receptor, also known as the RARA gene, is present on the chromosome number 17. It fuses with the PML gene that's present on chromosome 15, which is going to form the PML-RARA fusion protein. This one is going to block the myeloproliferative differentiation and promote renewable accumulates in the bone marrow. And retinoic acid treatments have shown to induce the myeloblast differentiation. Now, coming to the last important slide, it's basically the different translocations that occur in different types of lymphoma, which is very important for you guys to know. You have to know the translocation, the affected gene, and what is the associated type of lymphoma. And those are the questions that you could use for practice. Now, continuing with immunology. Basically, immunology is just going to be a summation of the pathology, the genetics, and also a bit of pharma. So we're going to start with hematopoiesis. It's basically, hematopoiesis means the productions of red blood cells, white blood cells, and even platelets. And that mainly takes place and happens in the bone marrow, in the spongy part with the stem cells. Then the stem cells are going to differentiate into two types: lymphoid stem cells and myeloid stem cells. The lymphoid stem cells are only going to give us white blood cells اللي هم that are going to become the lymphoblast. Includes B cells, T cells, and sometimes Anki cells, but to a lesser extent. The fact that the Anki cells come from the lymphoid stem cells is very important. While the myeloid stem cells, they are going to become myeloblastic, so they can be mature to become monocyte, granulocyte, like the neutrophils. They can also produce red blood cells and platelets. So we're going to have mainly two different stem cells: the lymphoid, which will majorly give us B cells, T cells, and Anki cells, and myeloid, which will give us monocyte, granulocytes, RBCs, and platelets. And this is the picture that's present in the immune slides. As you can see, how the lymphoid progenitor gave us the T cells, the B cells, the Anki cells, and the cell as well, while the myeloid gave us the neutrophils, monocyte, dendritic cells, eosinophils, red blood cells, and platelets. Now, moving on to the symptoms in acute versus chronic leukemia. Malak went over them, but we're just going to quickly go over them very fast. So what are the differentiated symptoms in acute? It's basically you're going to have pale skin, bruising or discoloration under the skin, bleeding problems, unexpected weight loss, or bone or joint pain and fever. The bruising and discoloration, because the bone marrow is constantly synthesizing a large amount of WBC, so the synthesis of the platelets and the RBCs is going to get less. So if there was a microtrauma that are usually fixed by the platelets that are not going to normally result in bruising, is going to go down. So the ability of the body to heal itself and plug those micro injuries is going to be reduced. That's why they're going to present with bruising. Now, symptoms of chronic leukemia, it's going to include the presence of swollen lymph nodes. They appear as lumps that are present in the armpits, neck, groin, abdominal pain, with also abdominal pain and bloating. To determine the different type, whether it was acute or chronic, we use CBC, peripheral blood smear, flow cytometry, and genetic testing. Now, generally speaking about leukemia is further classified into chronic and acute. Acute is further again divided by the two lymphoid lineage. The stem cell lineage, whether it was the lymphoid or the myeloid. So we're going to have acute lymphocytic leukemia and acute myeloid leukemia. Same thing, chronic lymphocytic leukemia and chronic myeloid leukemia. Okay, so chronic means it happens at a slower pace, so it has a very better prognosis, while the acute one gets worse very quickly, which means the cells are going to rapidly proliferate and the patient is going to become symptomatic. So there's also this additional type known as multiple myeloma. Multiple myeloma is the cancer of plasma cells. You just have to keep this point in mind. Plasma cells meaning the activated mature B cells that start producing antibodies. Because before a B cell become mature, it's called a B cell. But after it becomes activated and start producing antibodies, we call it plasma cells, and they abnormally accumulate in the bone marrow. This is going to result in disrupted normal blood cell production, and it's going to also result in the damage of the parenchymal tissue. Now we're going to quickly just go over the acute lymphoblastic leukemia. ALL is largely a disease of children and young people. Another way to remember it is acute. مين هم الناس الacute? It's basically children, so acute happens in children. It often presents with complications of bone marrow, including bleeding, infection, and anemia, as I just explained before, because of the massive amount of immature RBCs, so they will be more prone to infection. Yes, you do have a higher number of WBC, but they are immature and unable to perform their function. Anemia and bleeding is because of the reduction in the bone marrow ability to produce RBC and platelets. It could be of B or T cells, so it could be either B cells or T cells, but the majority are B cells, and they have a specific marker on their surface known as CD19. This is going to be very important when we're going to speak about the treatment. Now, because it's acute, so it tends to progress very rapidly and we need to intervene very quickly, we need aggressive chemotherapy, and for high-risk patients, we need allogenic stem cell transplantation. Another treatment is the use of CAR-T, which we will going to explain later on, because it's going to be targeting the antigen that is expressed by these cells, which is CD19. CD19 directed CAR-T therapy causes unavoidable B-cell aplasia associated with hypogammaglobulinemia. So why do we have hypoglobulinemia? Because the plasma cells are the ones that are going to give us the gamma globulins. If we kill those B cells, we're not going to have gamma globulins anymore. Now, moving on to the chronic lymphoblastic leukemia. Chronic, so it tends to occur in elderly. It's often very slowly growing, and many patients are asymptomatic until the diagnosis. Of course, you need to do genetic testing. Cytogenic and cellular changes are also detected by the microscopy. Chronic lymphoblastic leukemia. What is mentioned in your slide is the treatment approach. So at early stages, no chemotherapy. Untreated CLL risk that they're going to have recurrent bacterial infections because they're not going to have any immunoglobulins. And the treatment is going to start if the patient becomes symptomatic or they have complications such as autoimmune thrombocytopenia and hemolytic anemia. The therapies are going to be rituximab, PTK inhibitors, and ofatumumab, which is a humanized anti-CD20 antibody. Then we have the CML, which is going to be a myeloproliferative disorder involving mature granulocytes, which are the neutrophils, eosinophils, and basophils. It's currently associated with the Philadelphia chromosome, which I just explained earlier. The key features is that the oncogenic driver is the Philadelphia chromosome because we're going to have an active tyrosine kinase receptor. It's detected by the presence, and it's confirmed by the presence of the Philadelphia chromosome or the PCR that's going to detect the expression of BCR-ABL. Treatment is that since it's caused by the overactivation of the tyrosine kinase, we're going to use tyrosine kinase inhibitors to prevent its function. Now, there are other types of leukemia as well. We have Burkitt's lymphoma, Hodgkin's and non-Hodgkin's lymphoma, also hairy cell leukemia. It's a rare type, it's a rare subtype of the chronic CLL that progresses slowly. It has hair in its surface, and lymphoid stem cells may also produce too many diseased B cells. Okay, now we said that one of the possible treatments is the bone marrow transplantation. Now, what are the complications of bone marrow transplantation? Is that we can have a graft versus host response, in which, let's just say, someone's allogenic hematopoietic cells are you transplanted them, and they contain mature and memory T cells. So basically, let's just say this is the bone marrow of the donor and this is the recipient. If the bone marrow of the donor contains mature and memory T cells, once you're going to introduce them to the donor's body, they're going to start to attack the recipient's body, because they do contain memory of the original donor cells. They're unused to the proteins that are expressed by this recipient, and as a result we can have a graft or host. So basically, the donor's T cells are going to start to circulate in the secondary lymph nodes, and they're going to become reactive by interacting with the dendritic cells, and they're going to express effector CD8 and CD18s to enter the host and start causing injury, because they were not programmed to tolerate the recipient's proteins, and as a result we're going to have the graft and host. Now, understanding cancer immunity is very important to understand how cancer happens in terms of leukemia. So basically, you're going to have a trigger, or let's just say there was a fusion of we had a Philadelphia chromosome. One time the cancer cells are going to die. So the dying cancer cells are going to release their self-antigen, and this is going to be picked up by our antigen-presenting cells. Our antigen-presenting cells are going to go back to the lymph nodes and activate the T cells that corresponds to it. Then the T cells is going to become very active. They're going to go and kill those cells. This is what happens normally. However, in order for a cancer to become very out of control, several mechanisms tend to happen. So normally, those are normal cells. We as human are constantly undergoing exposure to the environment and genetic carcinogens, so we're going to acquire mutations. But because our immune system is in constant state of immunosurveillance, we can always maintain normal cells. However, what happens is in cancer, you're going to have malignant cells proliferation. At the beginning, your immune system is going to be very efficient, and then, as I just explained here, they're going to get rid of these cancer cells. So we're going to have the elimination. Then poorly immunogenic tumor cells is going to become in a dormant state. So it's not going to be killed, but our body is not going to be able to detect it. Then this cell, using different ways, we're going to explain them in a bit, they're going to be able to evade hide from the immune system until they're going to proliferate in a very enormous high amount, and then they're going to escape the immune system surveillance program, and then we're going to have the tumor progression with clinical manifestation. So it's not an overnight thing, it's a process that involved all of these steps. So it starts with immunosurveillance, elimination, equilibrium, escape, and then if the tumor escapes, we're going to have the tumor progression. So basically, what are the different immune evasion strategies? We have antigen modulation and the suppression of the anti-tumor. Antigen modulations is that the tumor cells are going to start decreasing their expression of the antigens, because if what our lymphocytes or our immune cells read, they kind of read the antigens. So basically, when they're going to remove the antigens, our immune system is not going to be able to recognize that this is an abnormal cells, because it's not expressing any abnormal proteins. It can also suppress the anti-tumor response by inducing the Tregs. So basically, some of the cancers have the ability to activate Tregs and regulatory T cells. They can suppress the immune response, and it's like the brakes of the immune response. They tell them, hold on, this is not a foreign subject. It's just one way cancer can trigger, can deceive the body. We also have myeloid-derived suppressor cell. They have anti-inflammatory function, and they contribute to the immunosuppression by interleukin-10 and tissue growth factor beta. So the cancer cells, some of the myeloid ones, they have the capability to produce these two, which is also capable of suppressing our immune system. The third mechanism is by the modulation of the MHC1 expression. So basically, they're going to down-regulate their expression of MHC. So this is going to make the T cells blind. Yani T cells need MHC to see. And if you down-regulate them, then the MHC cells won't be able to recognize you. However, the Anki cells are going to be able to recognize that MHC class 1 cells are not present, and they're going to kill the infected cell. Last but not least is the expression of the immune checkpoint markers, and this is what we call exhaustion. Basically, the immune system is going to, the cancer is going to start producing CTLA and PD-L1. These two, CTLA and PD-1, are going to prevent the immune system from producing its normal immune response, because CTLA is going to block the B7, so it's going to prevent the CD28 co-stimulation that is required, because we know that for a T cell to become activated or for a B cell, they require co-stimulation. There's also PD-L1, which interacts with, which is basically going to stand for programmed death protein. So this is going to promote the death of the T cells. All of these mechanisms are the way cancer cells use to escape our immune system. Now, coming to cancer immunotherapy. Cancer immunotherapy states that you're going to start using or developing ways in which you're going to enhance your immune response to the cancer, which is going to help you in eliminating it. So basically, we have cytokine therapy. Cytokine therapy is that by providing them with interleukins 2 and gamma and alpha interferons. Monoclonal antibodies is basically, let's just say, we said here, and now we have the antigen. I was mentioned here. Where was it? Yeah, the antigen CD20 by the B cells. So basically, you're going to just synthesize an antibody that is going to bind this antigen, and then it can help kill the cell. And then we have conjugated monoclonal antibodies are going to be, sometimes they're going to be connected to chemotherapy drugs. So instead of having this wide systematic effect, you can attach to this, you can attach the chemo. So let's just say this is our antibody. Okay, we can attach chemo drug to the antibody, and this antibody will only deliver this chemotherapy into the cells that express CD20. This is a way that is going to help us reduce a systematic effect. Or sometimes we can activate, we can also attach a radioactive particle, which is going to be used as homing devices to take one of these substances directly to the cancer cell. Okay. And we also have the induction of the anti-tumor immune system. So basically what we're doing here is that you're going to enhance the capability of your T cells to figure them out. So basically, if you look here, we have the dendritic cells, and this is the tumor peptides expressed on the MHC. Then you have co-stimulation, they kill the tumor cells. In CTL mediated, same thing, but because of the expression of the PD and PDL, and if you basically prevent this from happening, you can have the killing of the tumor cells. So here in this mechanism, we're just trying to decrease the PD-L1 effect on our T cells. Then we have the CAR T therapy. It's a single chain antibody that is going to form as a binding site for a tumor antigen. So basically, CAR T cell therapy is going to be the CAR T cell therapy, okay? And this is going to be the tumor antigen. This is going to activate the T cells so this is going to be the chain that is going to be bounded to the tumor antigen. Once this tumor antigen binds to this chain, the T cell is going to become activated, and it's going to start killing the tumor cells, okay? Because the tumor-bearing patients, this process is done by you're going to have a patient that's going to contain one of the leukemias. You're going to isolate the lymphocyte from the blood or from the tumor infiltrate. You're going to expand them in culture, and you're going to with interleukins 2 and then transfer them with the CAR gene. The CAR gene is going to be this a single chain antibody, that contains heavy and light chains. Okay, you're going to attach this CAR thing to it, and then you're going to transfer it back into the patient. This highly reduces the graft versus host because it's basically the host own lymphocytes. You're going to transform them back, and then these immune cells are going to move into surveillance. Once this single chain antibody binds with the tumor cells, it's going to activate those T cells and causes their death. Okay, and then we have the dendritic cell cancer vaccination, where basically you're going to take the dendritic cells, because if the dendritic cells were able to find out the antigen, they're going to be able to present it to the T cells. You're going to vaccinate them with the tumor antigen, then you're going to transfer them back. Then these dendritic cells, if they were able to detect it with this because of the vaccinated tumor antigen, they're going to go and stimulate the T cells, and we know how potent the T cells is in killing it. I think to clarify the confusion, it's basically the vaccinated tumor antigen that is going to be expressed by these dendritic cells, which is going to activate the CD cells. And those are also questions for you guys to practice on. Okay, so now moving on with pharmacology. Pharmacology is going to be entirely based on your understanding of the genetic and the immune mechanism. So basically, the current treatment options that are present for leukemia is that the tyrosine kinase inhibitors, chemotherapy, such as interferon alpha, and then we have the third line, which is basically the hematopoietic stem cells transplantation. Now, we have 3 generations of the tyrosine kinase inhibitor. The first generation, which is going to be the imatinib, we're going to use this type of tyrosine kinase inhibitor. It's going to be specific for the ABL, c-KIT, and alpha and beta PDGFR, which is going to be responsible for the growth. Okay, this imatinib is going to be used in cases of CML, ALL, gastrointestinal stromal tumor cells that are going to express specifically the c-KIT gene, and myelodysplastic diseases that are associated with the PDGFR. It could be either alpha or beta. You can use imatinib. Now, imatinib is going to be the first generation. However, there could be mutations which is going to result in the resistance. So when we have resistance to imatinib and the patient is no longer getting better, we will move on to the second generation. The second generation is we have the dasatinib, which is also an oral inhibitor for several kinases, including BCR-ABL, c-KIT, SRC, and this time the PDGFR, but only the beta. So imatinib, you can use it for alpha and beta, while the dasatinib, you can only use it for beta. Now, different forms of imatinib are going to bind for this, as the dasatinib is going to bind into a different binding site, which different conformations from the ABL kinase domain, which is going to overcome the resistance. So if this was the gene, the dasatinib is going to bind here, while the imatinib is going to bind here. So they're going to bind at 2 different sites. That's why it can help overcome the resistance. Their clinical use, they're used also in CML and ALL, however, with positive Philadelphia gene. They're also used with gastrointestinal stromal cells that are going to express c-KIT. Then we have nilotinib. It has a higher binding affinity for the ABL kinase. It's also used to overcome the imatinib resistance, and it's approved for the chronic phase and accelerated phase of CML. These 2 phases could be a keyword into which type of kinases you would use. Then we have the third generation, which is going to be the ponatinib and the I'm not sure how do we pronounce it, but basically it happens because there was a threonine to isoleucine switching, okay, which is going to help cause a resistance to the first and the second. So the second overcomes the first, but due to this kind of change, we can have resistance to both the first and the second generation. So that's why we have came up with the third generation. So ponatinib is an ATP competitive tyrosine kinase inhibitor, while this one is going to be allosterically inhibiting it. Yani it's non-competitive, while this one is going to be competitive. Asciminib specifically targets the ABL myristoyl pockets, and it's going to be on an allosteric site, not on a competitive site. The side effects that are associated with ponatinib is going to be arterial and venous thrombus, which has a high cardiovascular risk, hypertension, hepatotoxicity, and pancreatitis. I've noticed that all of these side effects were mentioned in your slides. Back at our time, we had to remember specific ones, so please refer to the doctor for what you should know specifically. But I would say focus on the very important ones. Nilotinib can prolong the QT interval, causes hyperglycemia and pancreatitis. Dasatinib can also prolong the QT interval, and cause platelet dysfunction. This one also causes pancreatitis, while ponatinib also causes liver toxicity, and they're all mentioned here. As we have finished the tyrosine kinase inhibitor, hematopoietic stem cell transplantation, it's the treatment of choice for younger patients because of its potential to completely cure. With the introduction of imatinib and the second generation of tyrosine kinase, there has been a shift of practice with an hematopoietic stem cell transplantation is not recommended as a first-line therapy. So this was before recommended as the first line, but now it is reserved for third line or special circumstances. Now we have the palliative care with cytotoxic agents. We can use interferon alpha, which was the former first-line agent. Now it's combined with the newer drugs for the refractory cases. We have the hydroxyurea, which is a myelosuppressive agent for the inducing hematological remission. And then we have the busulfan, which I think you took last semester. It is used for myelosuppressive agents for inducing hematological remission. It's a chemotherapy drug that is cell cycle non-specific, and it's what type of agent? An alkylating agent that is going to result in the damage to the DNA. Then last but not least is the omacitaxine. It's a protein translation inhibitor. It basically inhibits the initial elongation of the protein synthesis by binding to the ribosomal A site. So basically this is the ribosomal A site. You're gonna block it, so you can no longer continue the elongation step of the protein synthesis. This is going to halt the protein synthesis, and the cancer cells will no longer be able to synthesize proteins. It is used for the chronic or the accelerated phase of CML with resistance or intolerance to two or more tyrosine kinase receptor. If you guys focus, you can see that this phrase has been repeated into two cases. So you would use nilotinib into the chronic and accelerated phase. If there was resistance or they're not responding, you can use the omacitaxine. And then we have, that's it.
Okay, so reaching the last part of this session, which is histology. Now, general histology, if you open the slides, you're going to feel like they're very overwhelming. The slides are very long. But if you focus on what the doctor says during the lectures, and whatever she says is important, take it for granted. It's going to be in your exam. Yeah, it's going to be important, and it's going to come. Okay, so I'll just briefly explain the general features of lymphoid tissue, since the questions are going to be very, very easy and straightforward. Okay, in the exam, the main lymphoid tissues that are discussed were four, which are the lymphoid, the thymus gland, the spleen, and the tonsils. Now let's go one by one, easy and short. For the lymph nodes, what you need to know is that there are general features which are stroma. طيب, and this stroma includes the capsule and the trabeculae. Now, plus it includes a reticular network. Now, this reticular network is a specific feature for the lymph nodes, and you may not find it in the other lymphoid tissues, but for the capsule and the trabecula, no, they're gonna be there. Hello, what's the trabecula exactly? It's like an extension from the outside to the inside of the parenchyma. Or like throughout the capsule, okay? And next, we have the parenchyma. طبعا we know medulla and the cortex, very easy and short, we know these things. What you need to know is that in the lymph node, when you visualize the lymph nodes, you're gonna enter, it's gonna be penetrated by the afferent. Then you're gonna go through the medulla, the cortex, and then you're gonna exit toward the hilum. You're gonna reach the afferents, okay? Okay, so as I mentioned, you're gonna reach the afferents. Okay, so we're done from the stroma and the parenchyma. There is also the sinuses. It's very important, which are spaces that are made of dense CT. Now we're gonna go through them more, but for example, plus for the parenchyma, you need to know that it includes follicles and lymphocytes. There is more information in the slides about the follicles, which are the dense, which are the lighter. You need to know some of these information. Plus, you need to know that it is formed by medullary cords. Okay, and now the function of these sinuses, as I mentioned, is to for the filtration of the lymph by the macrophages as it passes from the afferent to the efferent. Okay, now we're done from the lymph nodes. Thymus is also easy. What you need to know is, again, the stroma has as usual يعني capsule, trabecula. Over here the trabecula is derived from the capsule. It's extending from the capsule, and it's the one that's responsible for dividing the thymus into two lobes. However, you need to know that these two lobes are incomplete. These two lobes each involve two incomplete or like general incomplete lobules. Okay, now for the parenchyma, as we mentioned, cortex, medulla as usual, but you need to know that the cortex over here is super dark. Why? Because we have infiltration of T lymphocytes. Okay, for the medulla, it's lighter and it's pale. It's a pale center, because there's less infiltration. Something very important here to know about the parenchyma, specifically the cortex over here. The cortex, what are you gonna see? You're gonna see three main features. The T, as I mentioned, the T lymphocyte filtration at the periphery. That's why it gives it its dark color. Plus, very important, the reticular epithelial cells. Okay, and these cells are responsible for the secretion of certain thymic hormones. This is important to know. Plus, there are a few macrophages. طيب, we're done from the cortex. The medulla has exactly the same features as the cortex, but plus something very important in the medulla is that it includes the Hazel's corpuscles. Okay, just know this. What is it? And basically, it is a degeneration of the epithelial cells. Okay, as it's like degenerating and like being degraded. Okay, this is for the thymus. With thymus, you also need to know the thymic barriers. What are the thymic barriers? The main function of the thymic barriers is to separate the developing T cells in the cortex from the antigens so that no immune response happens until it fully develops. طبعا the main site is the cortex. Why? Because the T cells, they develop in the cortex. Okay, for the spleen. Again, as usual, something similar between the spleen and the lymph nodes is that they both contain reticular network. Okay, plus of course, as usual, the capsule and the trabecula. But over here, بالspleen, the trabecula is derived from the hilum. From the hilum. Okay, this is something to know. This is very important for the splenic lobules. It contains white bulbs and red bulbs. The doctor will mention a certain definition of each, and I remember in the exam this question came. طيب, you need to know the definition of each, and which I'll show you now in a bit. Okay, and طبعا you need to know that the red bulb is formed of splenic cords. Okay, بنسميهم biliroth. طيب, the spleen, as I mentioned, and a white and red bulb. بالwhite, what do you mean by white bulb? It's basically blood vessels, which is like a central artery, plus lymphocytes. Okay, it's basically a combination of both. For the red bulb, it's a blood vessel or an artery that breaks into the capillary or the small branches of vessels. Okay, plus we have lymphocytes. So that's the difference. With red bulb, there is a breakthrough of these blood vessels. See, يعني over here if you see ضلعوا over here we have what do you call it, blood vessels that's infiltrating or breaking through an accumulation of lymphocytes. Okay, but again make sure the doctor, she's gonna mention a specific definition of each, make sure to know. Okay, and yeah, that's it for this part. I hope you guys sincerely really benefited from this. Any questions, any hesitations, please don't hesitate to reach out. Ask me any questions you guys would want to know. And thank you very much and best of luck in your studies. والله يوفقكم يا رب ويسهل عليكم. Thank you.